last night. And the other thing too is if you play soccer, we do have a Okay, now we got to share screen again. Yeah. There we go. Okay. All right. Perfect. All right. Great. All right. So we're going to talk about cholesterol today. And so a lot of people ask me, well, why should we talk about cholesterol in the pediatric world? Well, it continues to be a problem, especially for our general pediatricians in the outpatient world. And I feel that they don't have a quite great grasp on what the values mean and when should they initiate a cholesterol lowering medications. So now we have a lot of additional tools that from a primary pediatric standpoint that they can use to help the general pediatrician to make that decision whether or not a child should be placed on a cholesterol lowering medication. So we worry about cholesterol because cholesterol is an integral part of cardiovascular health, and cardiovascular health is the leading cause of death in the United States and across other countries. And so we should talk about those and have a better understanding in managing in children with pediatric lipid abnormalities. Let's see. Just to let, let's see. Go. Oh yeah, sorry. Just checking. So there's my disclosures, and we won't be talking about any of those medications that we use. But just to let everybody know, I wish we could have gave this talk like 2 weeks ago, but it was National Triglyceride Day, if you didn't know that. So enjoy the carbohydrates and the high glycemic foods that we're eating today. And it's the one day that your triglycerides can be high, and we celebrate it. So I always like to bring this up too. So a lot of us have seen the pictures of Mona Lisa, and Leonardo da Vinci was known for his detailed work, and he has left us some clues in the Mona Lisa that has to do with dyslipidemia. And for how many times we've seen this picture, we've never really noticed it before. But I've never been to the Louvre, so from what I've been told is that this is what the scene sort of looks like. So it's very hard to see the details of the picture. But at the end of the talk, I'll reveal those lipid clues that are in this picture that we're all not aware of. So we want to talk about pediatric dyslipidemia, and we want to talk about the subclinical state and have a better understanding what that means in pediatrics. We want to talk about some of the blood biomarkers that we have available to us that are simple to use to help our general pediatricians to decide whether or not a child should be referred to subspecialists for cholesterol management, or whether or not they should be placed on a cholesterol-lowering medication. And the overall big theme is I want general pediatricians to really understand these two broad categories of children. We want to be able to recognize kids who have genetic dyslipidemia and kids who have atherogenic dyslipidemia. And these are the two broad populations that would require cholesterol-lowering medications. So in 2011, the NHLBI, which is the National Heart, Lung, and Blood Institute, released the Cardiovascular Integrated Health Guidelines. And it's a guideline, actually, here's it right here, I forgot, I brought it. So I don't know if everybody has seen this, but this is sort of the Bible for lipid management in kids. And it was released in 2011. And in those guidelines, they made one of the most controversial statements in the pediatric world. And that statement and recommendation was that all kids between 9 and 11 should be universally screened with a lipid panel. And this is regardless of family history, risk conditions, and risk factors. And this caused a lot of controversy in the general pediatric world because they were afraid that we were going to be putting every kid on a cholesterol-lowering medication. They recommended fasting or non-fasting lipid panel. And overall, the goal had two things. One, we wanted to identify children who are at risk for premature and accelerated atherosclerosis development, and to identify those individuals who may have genetic dyslipidemia. So 2 years after the release of the guidelines, I was interested in the pediatric providers and what their knowledge and understanding of the new guidelines were. And overall, what we found is that most pediatric providers were very uncomfortable in managing pediatric dyslipidemia, and they still continue to be very uncomfortable. Some of the barriers were that they had a poor knowledge of the lipid guidelines. They didn't know that the new guidelines were released. They were afraid of missing a genetic type dyslipidemia in the pediatric world. There was some confusion between what the normal and abnormal values were recommended in the guidelines, and they were very uncomfortable in initiating or starting a cholesterol-lowering medication, i.e. a statin. So what we know for sure is that atherosclerosis begins in childhood, okay? And we first became aware of this in the late 60s and early 70s from young soldiers who died in the Korean War and the Vietnam War. And when they came back and they died, they had all these autopsy studies. And in those autopsy studies, they found that a lot of these young soldiers already had signs of atherosclerosis in their vessels. And so that substrate, that foundation for atherosclerosis development in kids is the fatty streak, okay? So we can see that by autopsy studies. We have confirmed that with histological testing. We have done staining techniques to see that within the vessel in pediatrics. We also have non-invasive imaging techniques like the carotid IMT that can show intimal thickening and the fatty streak inside the vessels itself. So we have multiple studies that shows this. And so this is an important aspect. In the 70s and the 80s, it was initially reported that the fatty streak developed between 12 and 16 years of age. Since the onset of obesity, though, a lot of reports have now suggested that the fatty streak now begins between the ages of 4 and 8, and that's very concerning. So what is the subclinical atherosclerosis state in kids? So that usually describes two scenarios. The first scenario is endothelial stress or endothelial damage, which is the substrate for the development of the fatty streak within the vessel itself. And so most of the kids that we screen between 9 and 11 years of age are asymptomatic. And this is fueled by the risk factors in childhood. And so what we want to do as general pediatricians, so we want to prevent the addition and the progression of the fatty streak to the adult type ASCVD, which is the atherosclerotic cardiovascular disease, and which in adulthood they are symptomatic. So we have certain prevention strategies, and as primary pediatric providers, we should be practicing two prevention strategies. The one is primordial prevention, where we want to prevent the development of the risk factors in children. And then later on, then we want to practice primary prevention, which is controlling those risk factors and preventing those risk factors to develop into an actual clinical disease. As they get older and they develop the clinical disease, they would kind of switch our prevention strategies into more of a secondary prevention where they actually have the disease, but we're looking to reduce the complications of the disease state itself. So let's look at an example. So this is the common scenario that we see in the pediatric outpatient world, where we have an overweight, obese child, or we have a family history of the family having high cholesterol. So what we see normally on the traditional lipid panel is that the cholesterol may be high, and we tend to see this general pattern where the triglycerides are high and the HDL is low. And normally the LDL is pretty low. What we don't actually really appreciate, but it's just like the Mona Lisa picture, there are clues in the traditional lipid panel that we don't necessarily see unless you're looking at it. So that's what I'm hoping to show everybody today. And what we're looking for are these atherogenic particles, okay? And what that means is that they have smaller dense lipoprotein particle size. They have signs of inflammation. They have signs of insulin resistance, and we can use all these little biomarkers that I have listed there that can be used from just the traditional lipid panel that we get every day. So the PDAY study, which is the pathological determinants of atherosclerosis in youth, showed that by autopsy study that the more risk factors that a child has, the more likely that they will develop changes within the endothelium. And so those traditional risk factors included family history, adiposity, the glucose level, hypertension, cholesterol, smoking back in the day, because these initially came out in the 70s and the 80s, but now probably in our day and time, it's vaping, and their activity level. Now with our newer knowledge, they have also coined a new term, which are called enhancing risk factors. So these are additional risk factors on top of the traditional risk factors that we think about. And that includes non-HDL, ApoB, lipoprotein little a, high sensitivity CRP, which is a surrogate marker for inflammation, and endothelial dysfunction, which we can measure by non-invasive imaging techniques, insulin resistance. And as we also have discovered that we know that our environment and social aspects also affect those risk factors. So social determinants of health and adverse childhood events. And it's great to see that. I've seen some of the general pediatric notes that we do now screen for that, and that's a good thing. So here's a paper just showing that that the ACEs, or the adverse childhood events, does play a part in the development and the risk factors for developing cardiovascular risk in children. And we know, just like additional other risk factors, the more ACE components that you have, the more likely that a child may be at risk for developing obesity, insulin resistance, hypertension, and dyslipidemia. So what is cholesterol? So it's important to always remember to, especially in the pediatric world, that cholesterol is a precursor and it's an important biological substrate for all these other pathways, cell membrane components. It's a precursor to steroid hormone precursors. And why this is important to remember, because in my view, I don't think there's terribly an urgency to aggressively lower cholesterol levels in kids before puberty. And because cholesterol is an important still biological molecule that the kid needs during development. So let's look at the pathways in cholesterol itself to get a better understanding. So when we talk about cholesterol, we talk about the lipoprotein itself. And the lipoprotein is composed of two components, the triglycerides and the cholesterol esters. Out of those two, the one that we really care about that causes atherosclerosis is the cholesterol esters. Okay, they're hydrophobic, so they need to be encased by a hydrophilic membrane to be processed throughout the body. And attached to each lipoprotein itself is a little zip code, which is called an apoprotein. And it has two components. It has an ApoA and an ApoB attached to each one of them. Okay. What's important to realize is that ApoA is the zip code for good cholesterol, i.e. HDL cholesterol. ApoB is a marker for all the bad cholesterol, which we call atherosclerotic lipoproteins. Okay, so we want to remember ApoB. Okay, so there are two pathways, and all the roads end at the mothership in the liver. So just like today, we're having our snacks. We utilize the endogenous pathway. We eat, we absorb it through our gut, and then the fats get packaged into chylomicrons. It goes through our lymphatic system, through our heart, and then into our vessels. Once it gets into our vessels, it's basically the fat is cleaved off by an enzyme called lipoprotein lipase. And lipoprotein lipase basically cleaves off all the triglycerides because the chylomicron is a big molecule that has a lot of fat and triglycerides and not that much cholesterol ester. So it's just kind of shaving the fat off through the system. And eventually it gets kind of smaller and it forms into a cholesterol ester. So once it shaves off all the fatty acids and the triglycerides, we use that for energy. If we're not very active and we don't use it for energy, then we store that fat. If the system becomes overwhelmed because we're eating too many high glycemic foods and refined carbohydrates, then that cholesterol, those free fatty acids, or triglycerides have to go someplace. And usually they're stored either on the liver, in our gut, in our butt muscle, okay? So once those get to the liver, then we utilize the endogenous pathway. And the molecule that's released there is the VLDL, which is sort of the cousin of the chylomicrons. It contains a lot of triglycerides and not that much cholesterol esters. Same thing, as it goes through the system, it's cleaved by the lipoprotein lipase and eventually makes itself to the LDL, or the low density cholesterol, which has more cholesterol esters than it does have triglycerides. Okay. And then it's reabsorbed back to the liver via the LDL receptor. And that's important to remember there because this is the mechanism for genetic type dyslipidemia. If we have a mutation in our LDL receptors, we will have higher levels of LDL. Okay, so that's the mechanism behind that. So it's also important to understand when we order a lipid panel, we should understand how that result is resulted on a piece of paper that we see all the time. And this is one of the confusing parts for the primary provider. So the lipid panel that we traditionally get, that's composed of the total cholesterol, the HDL, the triglycerides, and the LDL, is based on density and size. Okay. And as I talked about before, the more, so when we talk about the lipoprotein particle itself, it's composed of triglycerides and cholesterol esters. The more triglycerides you have, the fatter the molecule is going to be. So that's why you have chylomicrons and VLDL, that's why they're so fat, because they have a lot of triglycerides. But as they get shaved through the system with the lipoprotein lipase, what we're left with is the LDL particle that contains more cholesterol esters. Okay, so if we look at the little cartoon diagram, we can see the yellow. That's all the triglycerides. You can see how fat those molecules are. And what we really care about is the sort of the pink shaded part. And there's a little clue right there. Underneath where it says bad cholesterol, you see that term non-HDL. This is a good another good surrogate marker that we can use from the traditional lipid panel to recognize all the potential atherogenic lipoprotein particles that would put a child at risk for developing atherosclerosis. So now we need a little bit background information, and this is where it gets a little confusing, I think, for the general pediatrician, because I think we reflect a lot of our pediatric management of lipids based on what we hear about in the adult world. And as we have always been told, children are not smaller adults. Okay, so in the adult world, they have some differences. And so let's look at those differences. So in the adult world, when we typically talk about adult, we are talking about at least a 40-year-old individual, and they usually already have the developed risk factors that's a part of them, and they're usually non-modifiable. Whereas in pediatrics, they have emerging developing risk factors, and those are modified. Okay, when we talk about their risk for developing atherosclerosis in life, it's based on a 10-year risk score for the adults. In pediatrics, we talk about a lifetime risk, which is generally 30 years. Okay, the adults have a risk calculator, and here's a little picture of it. You can download it and put your information in there, and it will tell you your risk of developing atherosclerosis in your life in the 10-year risk as an adult. In pediatrics, we don't have a calculator. Okay, in the adult world, their primary job is to prevent a cardiovascular event or death, and they do this by primary and secondary prevention strategies. In pediatrics, our real main goal is to prevent the establishment and additional risk factors, and we do this through primordial and primary prevention, as I talked about before. And overall, our goal is to prevent premature and accelerated development of the fatty acid to develop atherosclerosis disease later in life. So here are some of the level of evidence and recommendations for pediatrics, but there are some highlighted things that I wanted to talk about. So still the cornerstone for obesity, central hypertension, and dyslipidemia is lifestyle counseling and lifestyle therapy, and it has a 1A green recommendation. If we look at the second one, the 2A, which is the yellow one here, this is another key clinical thing to remember, that any child or adolescent 10 years and older who has an LDL persistently greater than 190 tends to be associated with familial hypercholesterolemia, which is the genetic type dyslipidemia. So remember 190. If you have an LDL greater than 190, more likely they have a genetic type dyslipidemia. Pretty easy. And then lastly, we look at number 7 here, which has a 2B recommendation that they put for universal screening. Again, as I talked about before, the controversial recommendations were that all children between 9 and 11, regardless of family history, risk factors, and risk conditions, should be screened with a lipid panel. So here is the 2018 last adult lipid guidelines for the adults in terms of primary preventions. And there are some things on here that we can take away and extrapolate in the pediatric world. And as we talked about before, just recently, that in all adults and in all children too, if you have an LDL that's greater than 190, they recommend high intensity statin, which in our world, in the pediatric world, is a genetic type dyslipidemia. Okay. If you have diabetes, you should be placed on a statin. Same holds true in the pediatric world. The highest risk factors for in the general pediatric world are children who have insulin resistance, type 1 and type 2 diabetes. We go to the next line. I have some things that are highlighted. They have some of those markers that I've kind of alluded about. If they have additional enhancing factors such as elevated ApoB, high sensitivity CRP, and lipoprotein little a, they should consider being put on a statin medication. We look down to the next one. If there are signs of inflammation, should be considered starting on a cholesterol lowering medication. And then the last two ones just really shows those risk calculators, percentiles for an adult, and what type of statin medication they should be put on. And then lastly, there is one little tiny segment in the adult lipid guidelines that has something about kids. And it says any children and adolescents ages 0 to 19 with a clinical diagnosis of familial hypercholesterolemia can be safely placed on a statin starting at the age of 10. So that's very important to know. So again, an LDL greater than 190 more likely has a genetic type familial hypercholesterolemia. And that's important for the general pediatrician to know. So it says, yeah, so it can be safely started at 10 years of age. The only exception to that would be someone who has homozygous familial hypercholesterolemia. Most kids that we see have heterozygous familial hypercholesterolemia, which just means they got the mutation defect from one parent. If you're unlucky, both parents had the mutation and the child received both mutations and they're homozygous, and their LDL cholesterol are usually in the thousands and they need to be on multiple medications. So in 2007, the American Heart Association looked at additional risk factors or risk conditions that are more specific to the pediatric world. And so let's take a look at some of those. And they develop a treatment guideline for each one of those. But in terms of the high risk for the general pediatrician world, as I mentioned before, the highest risk factors are people who are kids who have diabetes, type 1 and type 2. Okay, so should be considered, definitely be putting on a cholesterol, depending on what their levels are. If we go to the moderate, severe obesity falls in that category. And then the at-risk are the insulin resistance. So those are the most common populations that we see in the general pediatric world. In terms of cardiology, for my cardiology guys, Kawasaki's with persistent aneurysms, someone who has had a coarctation repair, anything with a coronary should be considered to be placed on the cholesterol lowering medications. In terms of primary dyslipidemia defects, familial hypercholesterolemia, if you have heterozygous or homozygous FH, and also you can see moderate risk too. You can see the little lipoprotein, LPA little a, and that's again one of those markers that we can measure in the pediatric world. So what are some of the tools that we have for the general pediatrician to use? We have blood markers, and we have non-invasive techniques. We also have other cardiovascular imaging techniques that can measure endothelial dysfunction, okay? I like to think of the blood markers in 5 broad categories. So we have the traditional markers that includes the lipid panel and hemoglobin A1C. We can measure particle size, and the two things that we can use is non-HDL and ApoB. In terms of lifetime risk, so 30-year risk in pediatrics, the two that correlate very well are persistent non-HDL levels and lipoprotein little a. In terms of insulin resistance, we can measure insulin, and a new and emerging ratio that's been out in the pediatric, in the lipid world, is the triglycerides to HDL ratio. And then in terms of inflammatory markers, we have high sensitivity CRP and oxidized LDL. So we can use these in the outpatient pediatric world to give us a better feel of who's at risk and who should be placed on a lipid lowering medication. So this is just a table from the guidelines that shows normal and abnormal values. What's important here, where I see a lot of confusion from the outpatient pediatric world, is when we order a traditional lipid panel, the levels that are reported as the reference range on LabCorp and SonoriQuest is the acceptable range values. So oftentimes when I get a referral, the lipids are all lit up. They're bolded or they're red, but they're not actually abnormal. Abnormal is greater than the 95th percentile, and they're in the high category. So for example, let's say you order a lipid panel, the pediatrician orders a lipid panel, and the total cholesterol was 175. On that piece of paper, it's going to be red and bolded, and they're like, oh my gosh, this kid has a lipid disorder. But in general, we don't really worry about it until it's at least above 200. So that's one of the downfalls that I see a lot of referrals that come to me. When we talk about those additional lipid markers that we can use, we do have normal values for the pediatric world. We have, as I talked about before, non-HDL, and we'll talk about what non-HDL means, but the non-HDL level should be less than 145 in the pediatric world. We have ApoB, which is the zip code for all atherogenic particles, and it should be less than 110. We also have normal values for the lipoprotein little a, which is the highest independent risk factors for developing atherosclerosis in the pediatric world, and we have normal values for those. So when we talk about the traditional lipid panel itself, we have the total cholesterol, we have triglycerides, LDL, and HDL. What we have to remember is that the traditional lipid panel is really just a surrogate marker for all these other things. So when we talk about triglycerides itself, it's really just a big molecule that's a surrogate marker for all the chylomicrons, the chylomicron remnants, VLDL, and IDL. And again, these all have an attached ApoB marker on them, which is the marker of atherogenic particles. The LDL is really a surrogate marker for all the cholesterol esters, and it's the cholesterol esters that we really worry about. It is also a marker for small density LDL particles and oxidized particles and in a part lipoprotein little a. And again, attached to those is an ApoB zip code. HDL is the good cholesterol, and it's a reflection of all the small particle HDL particles, and it has an ApoA zip code to it, and that's the good cholesterol. That's the one we want to be high. And then we can also traditionally measure the lipoprotein little a. So the most recent big cardiovascular trial that was done in the adult world just recently was looking at the diabetes population and the effect of lowering triglycerides using a fibrate. But what they came to the conclusion of is that we can stop worrying about triglycerides because triglycerides do not affect the overall cardiovascular outcome for cardiovascular events and death itself. So they said, if our goal is to prevent cardiovascular events, we need to focus on cholesterol particles. And so we have ways to measure cholesterol particles because those are the particles that can clog the heart, and it tends to be a more useful strategy. So we can do that in pediatrics too. So size matters. You can have a whole bunch of individuals with the same cholesterol level. So in the little cartoon diagram, everybody can have a cholesterol of 125, but there are certain people who are at more risk than others. And this has to go due to the fact of particle size itself. So as I mentioned before, when we talk about the traditional lipid panel is really based on density and size. So if you have the bigger type cholesterol pattern, you're not at risk as much versus the lady that's on the far right that says high risk, she has smaller particle size. So the thought process behind that is that these little tiny particles are able to squeeze their little lipoprotein butts between the endothelium and cause a chain reaction and cause inflammation and start the cascade reaction for atherosclerosis and the fatty acid and the fatty streak development in pediatrics. So we have two markers that we can assess in the pediatric world to analyze for small particle size in pediatrics. The first one, as we talked about here a little bit, was the non-HDL, and the non-HDL is a very useful marker, and it's nice because we can use it from our traditional lipid panel. Non-HDL is a surrogate reflection of all the atherogenic subparticles in the body, and all you have to do is take your total cholesterol minus your HDL, and you will get your non-HDL level. In general, it should be less than 145, and you can see by the cartoon diagram, it's a reflection of all the atherogenic subparticles. And also, you can also notice that each atherogenic particle, there's an attached zip code of the ApoB. We can also measure ApoB. And a lot of studies have shown that ApoB might be a lot more superior than LDL cholesterol and non-HDL itself. And we can measure that. And as I talked about before, we have normal levels for ApoB in pediatrics. Okay. So in terms of like small particle size, we have non-HDL that we can get from our traditional lipid panel through our calculation, or we can measure it directly with ApoB levels. The European Society just recently came out with this nice little diagram, which basically shows all the primary and secondary LDL cholesterol trials that were performed in adults. And what we know for sure is that LDL levels correlate with cardiovascular events. But what they later found out was the people who were at risk for a cardiovascular event were those who had small particle LDL size and who had oxidized LDL particles. So the oxidized LDL particles is the mechanism of how we get these small LDL particle size. And again, once they're small, they're able to squeeze themselves through the endothelium and cause that chain reaction for the development of atherosclerosis. Now, in terms of lifetime risk for pediatrics, we have two markers. So in the adult world, they talk about a 10-year risk. In the pediatric world, we talk about a 30-year risk. And those two markers are non-HDL and lipoprotein little a. Okay. So by the little graph, you can see if a child has persistent elevated non-HDL, which is a simple calculation that you can do on your traditional lipid panel, more than likely they will have a lifetime risk of a cardiovascular event in the future. And this can track into adulthood. In terms of lipoprotein little a, they mentioned here in the article that a child with high lipoprotein little a and high LDL cholesterol had a 4 times greater risk of developing atherosclerosis. So those are the two markers that we can utilize for lifetime risk in a pediatric patient. So what is lipoprotein little a? It is the strongest independent genetic risk factor for cardiovascular disease that we have. You're either born with it or you're not. Okay. There are some recommendations on how we should screen for it, but generally most of the time, the way that I see it is either there's known family history and someone measures it and no one knows what to do with it, or a child has some sort of arterial clot and the hematologists order it. And the question for me usually is like, should they be replaced on an aspirin? The clots and the cholesterol LPA level are two different mechanisms. But why lipoprotein little a is deadly is because it has this trifecta. It's pro-inflammatory, it's pro-thrombogenic, that it can form clots, and it's also pro-atherogenic. The lipoprotein little a is really the bad cousin of the LDL particle itself. In terms of kids that we see with overweight and obesity, another useful marker that we can use is the triglyceride to HDL ratio, which is a good surrogate marker of insulin resistance. And again, this is a very useful one because we can use this on the traditional lipid panel. Just take your triglycerides and you divide by HDL. And it correlates well for those kids who are insulin resistant. So insulin resistance is the underlying issue in most of the overweight, obese kids that we see. And it affects all of us. Usually our insulin levels are not able to drop. So if your insulin levels are always high, you're always in this fat storage mode, okay? And you're not able to utilize the glucose that you use. And we see this a lot in a lot of us. We're like, try to lose weight, I'm trying to eat healthy, but there's so much hidden glucose in the foods that we eat that our insulin levels are always high. And because they're always kind of high, they're never able to go down normal. We're constantly in this fat storage mode. And so then we have to store the fat, and the fat overwhelms the system, and you have these kids with high triglycerides. And so, for example, a lot of us will think we're eating healthy, like we'll eat a yogurt. And if you ever look at the back of a yogurt, the reason why it tastes good is because there's a high glucose load on there. In the back of it, it's usually anywhere from 20 to 30 grams of sugar in the back. So even though you think you're eating healthy with yogurts all the time, you're still getting a lot of hidden glucose that's raising your insulin level. And so what do a lot of us do on top of it? We put the granola bran mix on top of it. And that's even worse. I mean, those have like anywhere from 50 to 90 grams of sugar on top of it. A Snicker bar has only like 20 grams of sugar. So you can see, even when we think that we're eating healthy, you're constantly getting a whole bunch of hidden sugar that's raising your insulin level itself. And so that's what happens to a lot of these families. Even when they're trying to eat healthy, they're getting all these hidden sugars in their foods that's raising their insulin levels. All right, so now let's switch our mode of thinking. And we briefly talked about the genetic type dyslipidemia. So the most common mutation that we see in the pediatric world, and that a primary pediatrician should be able to recognize, is elevated high LDL cholesterol, which is consistent with familial hypercholesterolemia, or FH. Okay, so the most common type is due to the mutation of the receptor within the liver itself, and so the LDL particle is not able to be pulled in by the liver to be further metabolized, and it comes in two forms. It's either heterozygous or homozygous. And heterozygous is the most common form, and it's all over the place. I see a lot of kids that have heterozygous familial hypercholesterolemia, which means that one of the family members, either mom or dad, has the disease. So this is where family history is important. If mom, grandma, the uncles have all on a cholesterol medication or had some sort of cardiovascular event, more than likely they have familial hypercholesterolemia. And a lot of the times, we do a lot of what we call a cascade screening. We see the child, we make the diagnosis of familial hypercholesterolemia, and then we tell them to check the other children, and they all have it too. Okay. So the general pattern that we see that the general pediatrician needs to recognize is that the LDL is high and the non-HDL is high. The triglycerides are normal. Okay. So in general, if you have an LDL that's at least 190, as we talked about before, more than likely they have the genetic type familial hypercholesterolemia. Okay. And they will need lifetime cholesterol lowering medications, i.e. a statin. And these kids are the ones that need to be referred to a subspecialist. When we look at the use of statins in children, and more specifically in children who have familial hypercholesterolemia, the statins are very effective and they work. In terms of the general pediatrician, I think they're very hesitant to use statins because they're not familiar with it and they worry about safety reasons. There have been a lot of studies to demonstrate that statins are very safe in children. And we know this because we have to use it in kids who have familial hypercholesterolemia. That's the basic treatment to treat their disease process. So here in this article, they show the 20-year follow-up in kids who had familial hypercholesterolemia and the effect of statins. And you can see, compared to their siblings who did not have FH, that statins lowered their LDL, their total LDL cholesterol, compared to their siblings who were not affected. So statins were effective there. They also looked at the freedom of a cardiovascular event and death compared to the parents who were later diagnosed and then later placed on a statin medication later in life. But because of our screening techniques, we were able to recognize those children who have FH and place them on a statin, and their events were lower compared to their parents. So in summary, we should all remember from a general pediatrician standpoint that universal lipid screening should be performed between 9 and 11 years of age, regardless of family history, regardless of the risk conditions, regardless of the risk factors. Okay, a fasting lipid panel is the preferred method, but if we don't, we can use a non-fasting lipid panel. Overall, our goal is to identify those children who are at risk for premature and accelerated atherosclerosis. Those children who have the atherogenic dyslipidemia patterns are pro-inflammatory, they have insulin resistance, and they have a lot of small density lipoproteins. In terms of lifetime risk, we have 3 components. We can measure non-HDL, ApoB, and lipoprotein little a. Out of those 3, I would say lipoprotein little a is the best marker that we have. And then lastly, as we talked about before, genetic dyslipidemias. That pattern usually is a child with high LDL and high non-HDL levels. And these children will require lifetime cholesterol lowering medications. And then lastly, let's look at Mona Lisa. So Leonardo da Vinci was known for his detailed work. And if we look at Mona Lisa's hand on the top, or the extension part, there's a little bump there. And some people have examined her death, which is not really known, but also her family history. But this may be the first painting of someone who had dyslipidemia. So that could be a xanthoma over her hand. And then also she may have a little xanthoma, the corner of her eye there. So I thought that was pretty interesting. Despite us, how many times we see this picture all the time. But that's the end of the talk. And thank you for joining us today. Any questions? Yes.
Great talk.
Thanks.
Do you do gene testing for the familial hyper?
We can, but usually the phenotype that we get from is pretty probable. If they consistently have an LDL greater than 190, usually most of the time we'll say they're in the 200s to 300s. In general, a child or any adults, their LDL cholesterol shouldn't be that high. But the only time we really do the genetic testing is if they're resistant to the certain types of statins. So we can find out which statins better for them. But now we also have all these other emerging new cholesterol lowering medications that we can use. But no, in general, we don't necessarily need to do the genetic testing itself unless family requests it. Yep.
Generic sample that you get.
Yeah.
You know, you're asking, typically just like, oh yeah, dad, this high cholesterol, mom has this, grandma has this. I think it's the risk stratification.
Yes.
You can repeat the question for John.
Oh yeah. So I'm sorry. So again, so the family history, that's kind of borderline-ish. Yeah. Yes. Correct. Yeah. So usually, yeah, those family histories are kind of benign and they may have this or that, and there's really no strong indication. So unless they're between 9 and 11 years of age, there's not necessarily urgency to screen them yet, unless they fall in that broad category. So the kids like, 4 or 5, and they don't necessarily have, so I would say the next event would be obesity related type on top of that. So that's an additional risk factor. So if they do, then you may want to screen a lipid panel. A lot of the times too, it just kind of depends on, at least that I've seen in the outpatient clinical world. I've seen pediatricians get that exact same scenario, and they just measure it. And they get a traditional lipid panel, they get the hemoglobin A1C, they check the thyroid, and in general, most of the time it's pretty normal. So once it kind of makes it to me, I get a little bit more detailed family history. If they, so I should say what you can use from a general pediatrician standpoint when you get the traditional lipid panel is use non-HDL. That's the good marker. So if if the triglycerides are high and the HDL is low, you can calculate the non-HDL. So your total cholesterol minus your HDL should be less than 145. If it's 160, 170, that kind of raises your eyebrows a little bit. So they may have something underlying that just hasn't been revealed yet. So you may have to do a little bit more advanced testing, either with the ApoB of the lipoprotein little a, or repeat it. But because I've seen sometimes too, once we repeat it, sometimes it's a little bit more in the normalish range. And I should say too, the biggest mistake that I see in most outpatient pediatric referrals to me is a lipid panel that was not performed fasting. It's very common, because I think what happens is they order it and they get the results, and like I said, it's all lit up. It's red, it's bolded, and they're like, oh, go see endocrine, go see cardiology, and they don't necessarily look at the values itself. And then again, I think it gets a little bit more confusing because the reference ranges that they use in the lab are really just the accepted ranges, which is less than the 75th percentile. Abnormal is above the 95th percentile. But again, it's just bolded, it's red, and they're like, I don't know what to do with this. You have to go to cardiology. So
That's somebody who does a lot of screening, kind of gets borderline.
yeah. Yes.
How quickly?
So again, I would use non-HDL. Non-HDL. So if it's abnormal, your non-HDL is normal, then more likely it's probably normal.
But like, then so you screen between 9 and 11. When do you screen?
Yeah. So depending on the value itself, I would say anywhere from 3 months to 6 months. A lot of the times, and again, I would always ask too, the most important question that I usually ask most families is, was it done fasting too? That's really important to always ask. In fact, I saw 2 kids yesterday. They came from Kingman, and the other one came from Lake Havasu, and their lipid panel was not done fasting. And I said, it's hard to make any interpretation of what this really means unless it was fasting.
We got 3 good questions.
Yeah.
In the chat.
Oh, let me ask it. Can I ask it really quickly?
Yes.
Yeah. Yeah. 8 in general. The triglycerides. Yeah. But then again, you can use the non-HDL as that surrogate marker for any underlying issues.
You can reliably still use the LDL patient even if they have.
Correct. Yep. So again, when we see kids who are overweight and obese and they have high triglycerides and low HDL, I use non-HDL as that marker of whether or not they should be placed on a cholesterol lowering medication itself. Okay. So the non-HDL is 165, 175. That means that they probably have small particle size lipoproteins. Yes.
This question, if kids are on a 2nd generation antipsychotic and have elevated triglycerides, should I think about treating, or like you were saying, not be too concerned since triglycerides aren't linked to the cardiac event?
Yeah, so the only true indication to treat triglycerides is really pancreatitis itself. But most people feel uncomfortable, in the 200 to 300s, but in general, if they're less than 300, you could probably just watch. The other population that we do see are the kids who are on Accutane. Their triglycerides will go high. But in general, it's reversible. It's the same thing with the antipsychotics. It's reversible. Now, again, using non-HDL would help because, again, if they just get a traditional lipid panel itself, there may be other underlying things. They just assume it's from the medication itself. But in general, if their triglycerides are high, their non-HDL should be pretty low itself. But if the non-HDL is high on top of the high triglycerides, there might be something else brewing that they just don't know.
And then here's a request from an outside pediatrician. Can we have a nice condensed table for a general pediatrician for screening blood tests with the important markers with the latest recommendation?
Yes.
Do you have one, or is it one?
We'll have to make one.
Okay.
Yes. Yes. But yeah, so again, I don't know if everyone was here before, but has everybody seen this? So this is the lipid Bible itself, which is released in 2011, but it's got a lot of good information, but this is what we use to make those assessments. I've heard in the background that they're going to be updating the pediatric lipid guidelines, which will probably include some of the stuff that I talked about, because now we have a whole bunch more emergent studies to confirm those suspicions. and correlate with the adult studies itself. But great, it's 8:30 and I know everybody's got responsibilities and they're free to leave if they want to.